So TB is an infectious disease. It can affect anybody. But why it's affecting only particular population and why not other people? And if you see the global data, 95% of TB cases and 95% of TB deaths incurred in developing countries. And it's a major public health challenge, particularly for the poor people in developing countries. And the economic impact due to TB is enormous. And if you see the TB, the link between TB and poverty, if anybody gets TB, it causes disability and it causes work absenteeism and results loss of income. Then they push them into the poverty and it causes poor consumption, poor health, and aggravate the TB and poverty. This is a circular and cumulative process. In 2000, in 1993, WHO announced TB is a global emergency. There is a need to control tuberculosis. Then the TB is not only the disease, and again, already people are talking it's a socio-economic problem. In 2020, World TB Day theme, they formed Stop TB, Fight Poverty. It's a theme. And that time, there is a crucial questions looking for the answers. Like poverty helps the spread of TB or TB makes poverty worse? Can poor access TB treatment if you provide free? Does TB program reach the poor segment of the population? How we can make the TB program become the pro-poor? During this time, 1993, it's a global emergency. 2000, WHO announced TB and poverty, Stop TB is a Fight Poverty. Then NIRT has taken the responsibility to do the research and answer these research questions. And the last 2 decades, I joined as a health economist. Then subsequently, I become a TB economist. We have taken studies on these aspects. These are the studies like socioeconomic impact of TB on patients and family, socioeconomic impact due to parental TB on children, link between TB poverty, whether program pro-poor, perception on TB patient on physical, mental, social well-being, what is the cost to the patients, what is the cost to the program, and what is the health-related quality of life of TB patients, what's the prevalence in different economic segment of the population, what is the resource required for the TB control program, and interconnection between HIV program and TB control program, and the socioeconomic profile of the TB program accessed, and economic benefits of the DARTS program, and economic burden for TB patients diagnosed through the active and passive case finding. There is an intervention introduced. And what are the determinants of household catastrophic expenditure? Again, one of the goal to achieve no patients incur any cost, no time. This needs to be achieved since 2019. Then we have collected over a period to see the link between TB and poverty. It is a very close association between TB and poverty. And this is a study, an economic impact of patient and the family. It was conducted, and you can see that the indirect cost was high. If program is providing free treatment to the patients, still patients incurred indirect cost in terms of work days lost, work absenteeism, and if they go to private, they have to spend again medical cost. When we done the study, we found the rural patients incurred more debt due to their economic burden, and illiterate borrowed more money. And if they have a higher family income, they have a higher debt due to their ability to repay. And every year, when we project this cost to the country, it's a huge economic burden to the country. And again, economic impact on parental TB, it's already previous speaker spoke about that parents getting TB, it will affect the children of their family. They discontinue the children from the schools and send them for the work to support the family. And we have estimated 8% of the rural and 13% of urban children discontinued the school. If the parent is a male patients, the dropout rate was more. And again, TB will not affect only that generation. This will pass on to the next generation, affecting the children of the patients. And the impact on female patients, again, already the faced stigmatization. 69% of the rural, due to the fear, they won't discuss with their illness with their own spouse and friends and neighbors. And about 15% faced rejection from the family, and child care affected significantly because it's infectious disease. The family member will not allow them to take care, and sometimes they won't be able to take care for their children. And when we estimated this one for the country, and again, more than 100,000 women are turned out of their house due to TB, and more than 300 children are dropped out due to the from the schools. And again, we have done the after this during this study, then DOTS program was introduced in 1997 as a pilot. And there is a demand from the WHO and Government of India. We need to compare what is the cost between the DOTS and non-DOTS program. We have done this study, and DOTS program, it's a decentralized service. Patients supposed to get treatment closer to the residents. The travel cost is reduced. The responsibility to cure the patient from patient to the health system is shifted. If patient is not coming for the treatment, health system goes to their house and completes the treatment. Again, it's a well-defined, structured program. This was reduced significantly to the patient's cost. And if they are very regular on treatment, patients are, they are able to go for work very early. These are the findings we have done from the study. Again, we want to see whether this program is reaching those who needy population. Then we studied the profile of patients registered under the program. And again, 64% of the patients registered under program were from the low economic segment of the population. Then it indicates that the free subsidized government program is reaching the most needy population. And again, the treatment outcome by the different segment of the population in the poor and lower socioeconomic class, the default means lost follow-up was significantly higher as compared to the high. And it means, so the patients are regular on treatment. If they're better off after 2-3 months, then their priority will change. They will give the priority to go for work. Then the default is more among this particular segment of the population. Then again, perception of TB patients about their physical and mental social well-being, already Karuna presented. This is we provided the scientific evidence from this study. During the treatment, the positive emotions increased, because once the second month, if they are converted from smear positive to negative, they feel they are better off. Their positive emotions are increased and the negative emotions are reduced. Another one, the activities, particularly these are female-dominated activities. Their household activities such as cooking, cleaning, washing, carrying water, serving food, also significantly increased among the female patients. Then another very important observation, already the previous speaker mentioned, when they know the diagnosis they have a TB, then people more than 50%, they will get upset, worry, crying about the disease if they know they have a TB, tuberculosis. And again, around 9% in both male and female. Again, we have already done studies to see the gender sensitivity, sensitive things, and we found not much difference between the gender. Only prevalence is high among the males. But again, the suicidal thoughts, it doesn't matter male or female, both have a suicidal thoughts when they know they have a TB. And again, NIRT conducted series of prevalence surveys to estimate the burden of TB in the community. We have a unique opportunity to see the prevalence of TB in the community, collecting their economic status, and we found in the population living low socioeconomic status have a high prevalence of TB. That is 3.7 times higher as compared to the higher socioeconomic group. And we have linked in the economic parameter in like classical indicators, income, standard of living, landless, house type, and smokers and alcoholics, all the parameters. If you look into all the parameters, the TB was high among the poor as compared to the higher economic status. Then coming to the equity, in the prevalence survey, when we done, there is a observation, 29%, around 1/3 of the population is missing from the community for diagnosis. Who is this missing population? When we see, it's the most among the elderly population, male, illiterate, employed people, and if the family have a non-earning members and living poor quality house, and smear negative patients are missing from the community. Then barriers for accessing healthcare. It's a geographical barrier, diagnostic delay, non-compliance of diagnostic, completion of non-diagnostic procedures, cost and health-seeking behavioral issues, and missed cases. And we have done a study to find out what is the delay in diagnosis. It's patients around 60% need to travel more than 5 kilometers to access the diagnostic services. And for the shopping diagnosis, people will enter the first health facilities and they have to shift health facilities for shopping diagnosis. So people will go to private to government to public, like they have to shopping around the diagnosis. This causes delay in diagnosis. When we see the delay with the private and government, those who approached private hospital have a higher delay than the government hospital. Then we recommended government to involve private practitioners to reduce this delay in diagnosis. Then government has taken effort to involve private practitioners for the TB control. And again, a diagnostic dropout among pulmonary TB suspects. Then we have previously the diagnosis procedure, patients need to give 2 sputum for diagnosis, and it will take 2 days. They have to come again to know the diagnosis. Then only 11%, 87% completed the diagnostic procedures, or only 11% they are not able to complete the diagnostic procedure. And the reasons are personal reasons. 2 sick patients should not come to the hospital so frequently, and dissatisfaction with the health provider. Now the new diagnostic tools like GeneXpert, TrueNet, all these things made effort to reduce these dropouts and get the early diagnosis. And coming to the health-seeking behavior among the symptomatics, in the rural area, around 5.5% have symptoms suggestive of TB, whereas in the urban area, 3.9% have chest symptoms suggestive of TB. But in the access, 80% of these symptomatics in the urban area, they have taken action for diagnosis, whereas rural area, it was less. Due to the reason, they feel like symptoms are not very serious, and they have a pressure from work, and they don't have money to come to the hospital. These are the major reason not taking the actions. And again, the new concept like a catastrophic expenditure means if patients spend more than 20% of their family income for the TB treatment, it's a catastrophic nature. And again, TB control program aim to reduce this catastrophic expenditure. And again, immediately this needs to be 0. Then because of TB program is completely free and the patient, the treatment is taken responsibility by the program, the service is decentralized, patients are getting closer to treatment, this will reduce the catastrophic expenditure. Then what are the factors contributing catastrophic expenditure? We found the indirect cost was significantly high, and another reason is patients spend, those who are all only one earning member in the family, and smokers have a more catastrophic expenditure than the other population. Again, this study was done in 2 metropolitan cities in India. One is in Delhi, another one is in Chennai. In Chennai, we found again similar finding, and 31% of the patients registered under the program experienced catastrophic expenditure. Still, there is a need to effort to reduce this catastrophic expenditure. Then again, in NIRT, we have done the community active survey, that is active case finding. And the program is diagnostic patients with the passive case finding. It means those who have those who suffer from symptoms suggestive of TB, they have to come to the hospital their own, and they have to diagnose and start treatment. Whereas now, what we have tried in Tiruvallur district, we done the door-to-door community survey. Actively, we have gone to their house and diagnosed. This reduced significantly for their out-of-pocket expenditure and shopping for a diagnosis. Then we have recommended this strategy. Now, Government of India is recommending the active case finding for the TB control program. And again, we done the study to estimate the provider cost, how much the program is spending to treat per patient. It's around 2,000 rupees. It depends upon the category of the patients. And another study, again, so much of external aid is helping to control tuberculosis in India. And again, it's a global fund for global fund is spending a lot of money for TB control in India. Currently, government of India is developed a strategic plan. They have allotted a lot of money, and again, you can see this one from since 2017, they have spent a lot of money for patient social and nutritional support. That's a white color thing. They are spending a lot of money. And again, new initiatives, they are spending a lot of money. Investment is increased for the new initiative of TB control in India. Coming to the drug-resistant TB, it's a major contributor to antimicrobial resistance worldwide. It contributing to the public health threat. And again, 500,000 people fall with the Mdr Tb. And again, it's obstacle to TB care and prevention. Again, this treatment outcome is not up to the mark. And again, it has economic and social cost. Again, the access previously in the diagnosis is very difficult. Now the new diagnostic tools are contribute to diagnose early and detect more cases. And the survey conducted in India in major states, it's shown around 2 to 3% of Mdr Tb among the new cases and 12 to 17% among the reinfected cases. And the burden of coming to the India burden, it's account 24% of the recurrent TB cases, and second highest total number of MDR cases in the world. And scaling of culture and TST laboratories can contribute early and treat these cases. Despite these achievements, Government of India has taken so much of effort to detect and treat early, and India efforts to control Mdr Tb still suffer from the strengthening the laboratories and introducing the diagnostic tool and management of management of treatment. Again, if you start, it's a more drug related problems, and again, patients need counseling. These drugs are more toxic, and again, sometimes it's very expensive. The treatment success rate is around 50% only, and community now with government is aiming to detect these patients with the community based. So the researcher are making effort to shortening the treatment duration. It was 1.5 years to 12 months, now 6 to 9 months. So the stream, again, shortening the treatment, the stream study was done in Bangladesh, stream 1. They have suggested MDR can be treated with the shorter regimen. Then the first stream trial, India is not contributed. That stream 2, we are part in the study. This can provide, the study is going on. If we get the results, this MDR can be treated with a 6-month regimen. And again, we are also trying from the injectable to the oral drugs, which can be patient friendly and the patient can easily managed in the community. And the cost for Mdr Tb, the amount is very high, and health systems spend more money, and the health system cost to treat Mdr is 40 times higher compared to the susceptible TB. And the proportion of patient income spent for Mdr Tb is much more than the sensitive TB. And again, still Government of India is provided free of cost of treatment to all the patients. Despite free treatment, patients spend considerable amount for Mdr Tb, and we are expecting the shortening treatment duration may reduce the cost to the patients and the health system. And coming to the quality of life of Mdr Tb patients, the quality of life of patients suffering from TB is affected, and the impact is enormous, and the psychological domain also considerable, and the social domain remains much low. And again, research findings suggested there is a need for counselors for Mdr Tb patients. And again, another thing, early diagnosis and prompt treatment of Mdr Tb will reduce the disease severity and improve the quality of life. To summarize, the prevalence of TB is more in poor people in whatever way in terms of income, their region, and their vulnerability. And the patient and provider-centered barrier to the health system still persist, and high dropout due to the long time diagnosis is taking effort to reduce this delay. And with the passive case finding, chances of missing TB diagnosis is huge. And again, government is recommending the active case finding, and economic impact due to TB is enormous to the patients. In the early 90s, we are facing the financial constraints. Now government is investing a lot to control TB, and funding available for new initiatives, and apparent TB is considerable. And in a national TB elimination program, again, there is evidence poor have access to TB-free diagnosis and treatment, and it reaching the poor segment of the population. More patients returned to work, and death default was reduced, and it was higher in the lower segment of the population. Need considerations. And what I want to suggest from my presentation, there is a need to identify appropriate strategies to improve access care among low income and marginalized population. Government is taken now focused interventions to target this population for early detect and treat. And there is a need for increased knowledge among the symptomatics, among the health-seeking behavior. For example, nobody will think a cough is going to kill them. But the TB, if they're not taking action, this will be more dangerous. After HIV and this COVID, so much of awareness, people so scared, but TB is nothing new disease, a very old disease, still so much of awareness needed to make them to aware. Remove the barriers at different levels, health system to be sensitization for the health providers, and improve patient-friendly rapid diagnostic procedures to increase case finding, reduce delay in diagnosis, and improve the access. And again, reach out for the missing cases is a challenge. Thank you so much again, once again, and thanks for Director and Karigalan for this wonderful opportunity to share our results in this forum. Thank you so much for patiently.